We'll continue with our discussion of the respiratory membrane, looking at the relationship between the alveolus and the pulmonary capillary. So here we see the alveolus and the pulmonary capillaries, a cross section that wrap around each of the alveoli. So here too is showing the cell wall of, or the cell lining, I should say, of the alveolus, here shown in blue, and here we have the cell lining, the capillary, the pulmonary capillary, here shown in red, and here's a red blood cell. So these two membranes are in close proximity to one another, so as we inhale fresh oxygen from the outside, that oxygen is in higher pressure concentration in the alveoli compared to the blood, so it diffuses from the alveolus to the blood. At the same time, the pulmonary capillaries are bringing up used blood from the body to the lungs to exhale off the waste gas, carbon dioxide. So the blue arrow here shows the diffusion of carbon dioxide from the pulmonary capillaries into the alveoli. Now there's a worksheet posted in Blackboard that's important for you to be able to label and understand the concepts. So here is another view of an alveolus. This is an air sac, and from here would be the bronchioles leading up to the bronchi to the trachea and so on. So the air is coming in through this passageway here. So this we would label air, and here you have a word bank with the different terms. So air would be the term you would put in the box here, and this is the alveolus. This structure here is the alveolus, so you would label this alveolus. And what we find is on the inside lining of each of the alveoli is a layer of water, and that water provides a nice moist environment for gas diffusion, because that water is the solvent in which the gases, carbon dioxide and oxygen, will dissolve into to cross this membrane from the alveoli to the pulmonary capillary and vice versa. So this is called a thin layer of water that we find lining inside of the alveoli. Here we have blood coming into the pulmonary capillary through the pulmonary artery, from the pulmonary artery. So this is going to contain a high concentration of carbon dioxide, because it's blood that's coming from the body to the lungs, and the carbon dioxide that is in higher concentration here will be exhaled from the pulmonary as it diffuses from the pulmonary capillary to the alveolus. So this would be a high concentration of carbon dioxide in this box here. This box here is just referring to the pulmonary capillary. That's what the structure is here, is the pulmonary capillary. And this box here is pointing to these two arrows, which would indicate the diffusion of carbon dioxide. So that's this term here, set of terms. So this would be the diffusion of carbon dioxide. And then as that blood passes by the pulmonary, or by the alveolus, we see oxygen is diffusing out of the alveolus into the pulmonary capillary. So this arrow, this box pointing to this arrow, is referring to the diffusion of O2, or oxygen, coming into the blood from the alveolus. So the blood leaving the pulmonary capillaries, entering the pulmonary vein, would be high in oxygen concentration. So that's what would go in this box, high O2 concentration here. So we have this constant exchange of gases, as we can see here, across the respiratory membrane, where we have carbon dioxide leaving the pulmonary capillaries and entering the alveoli of the lungs, and oxygen leaving the alveoli of the lungs and entering the pulmonary capillary. So the process by which this occurs, where carbon dioxide and oxygen can pass through this membrane, is by diffusion. So the answer here is diffusion, and it's from high to low pressure. So we have gases exert a pressure as they are dissolved in a plasma, or that's primarily the number we use to describe pressure differences across the respiratory membrane, is the amount dissolved in plasma, the liquid portion of our blood. So it's always from high to low pressure. And then what we find is there's a special substance that helps to break down the cohesiveness between the water molecules that line the inside of the alveoli, because water molecules attract each other. And if a water molecule here on this side of the alveolus attracts a water molecule molecule here on this side of the alveolus, that could cause a water droplet to form inside the alveoli, and that would pull the walls of the alveoli closer to one another and could collapse the lung. So to break up the cohesiveness of these water molecules, a special substance is produced by the special cells of the alveoli, and they're called surfactant cells. Here we can see in this diagram these green cells that we find lining the alveoli. They produce a substance called surfactant, and what surfactant does is it breaks up the cohesiveness and helps to keep the lungs inflated. So in our worksheet here, the next question is, what special substance is secreted by some cells in the alveoli to prevent them from collapsing? That is surfactant. And we find that deep breathing stimulates these cells to produce surfactant. So when patients are lying in bed for a long time or taking high doses of pain medications where their breathing might not be as deep and active, we recommend using an incentive spirometer or deep breathing to get those cells to be stimulated to produce more surfactant, especially in the bases of the lungs. When people are lying around, they don't tend to take deep breaths, and the bases of the lungs can actually have small little collapsed areas. So it's very important that we practice deep breathing. And babies, it's very important for a baby's lungs to expand after birth that they have good surfactant production. And babies that are born premature don't have good surfactant production. And sometimes if they know a baby's going to be born premature, they can give a special medication injection to the mother to help stimulate surfactant production in the newborn. So going back to our respiratory membrane here again, we can see that we have a net diffusion of oxygen from the alveolus to the blood, and for carbon dioxide from the blood to the alveolus. Again, we call this relationship between these two structures the respiratory membrane. So we already talked about how oxygen diffuses from the capillaries into the tissues. Once it gets down into the body and away from the lungs and the heart, we want to see a constant feeding of the tissues with oxygen as they're using up glucose. And this process again happens by diffusion. So if we look at the process of ventilation, how we get air in and out of the lungs, that's a new concept. We have a pair of lungs bringing in air from the trachea via the bronchi, which branches into the secondary and tertiary bronchi, finally to the bronchioles, and leading to the alveoli. So if we look at the specific processes involved in breathing, we have to be aware of two important muscles. One being the diaphragm. The diaphragm is underneath the lungs, lies underneath it, and when it flattens and moves down, the lungs are able to expand. At the same time, the external intercostal muscles help to elevate the ribs and spread out the ribs to increase the chest cavity in that direction. So it kind of moves them from side to side, increasing the volume of the chest cavity. And then as those muscles relax, the diaphragm moves upward again and pushes the lungs upward. The ribs move inward, again decreasing the volume of the thoracic cavity. So we see these volume changes that cause pressure changes in the lung, and that's what drives our breathing. So there are, it's important that we recognize there are two membranes that are important to keeping our lungs expanded, and one is the parietal pleura that lines the body cavity, and that folds in on itself as it gets near the hilum of the lung, and then it covers the lung itself. So this membrane, which folds in on itself, leaves a space between the two layers, which is called the pleural space, and that is filled with fluid. That fluid has a negative pressure, which allows for the visceral pleura and the parietal pleura to have an attraction to one another. So as the chest cavity rises away from the midline during inhalation, the lungs follow with it. So we have a nice animation here to show you the process of ventilation. There isn't any sound with it, but it's a great animation here. Here we can see the diaphragm moving down, and the external intercostals pull the ribs out, and that causes the lungs to expand. We can see the lungs are getting bigger. So we have an increased volume. That causes a decreased pressure inside the lungs, and air flows in from the outside. And as those muscles relax, we see a decreased volume here, and air flows out of the lungs. So here we can see, as it relaxes, we have decreased volume, which causes an increased pressure, and air flows out. So our breathing is a matter of pressure changes as a result of changing the lung volumes. Air goes in as volume increases and pressure decreases, and air flows out as volume decreases and pressure increases. This is called Boyle's law. Boyle's law states that pressure is inversely related to volume, which means if my volume is increasing, that will cause a decrease in pressure. And if my volume is decreasing, that will cause an increase in pressure. So if we go back to our worksheet here that we were filling out, if we look at the steps of ventilation, inspiration is when we inhale. What happens is that the diaphragm contracts and moves down. So we could fill that in here. The diaphragm contracts and moves down. As a result, the volume of the lungs will increase. If we increase the volume of the lungs, that will cause decreased pressure of the air inside the lungs because there's simply more space now for that air to move around. And as a result of this decreased pressure, we're going to find higher pressure outside the body compared to lower pressure in the lungs, and that air is going to move inward. So here we would say air moves into the lungs. Now this air is going to continue to move in until the pressure outside the body is equal to pressure inside the body. And then those pressure differences, as they equalize, will stop the movement of air inward. And then as the diaphragm relaxes, so here the diaphragm relaxes and moves upward again. You would hit that here. Diaphragm relaxes and moves upward. That's going to decrease the lung volume. And if we decrease the volume, the air particles in there will be under higher pressure, so pressure is increasing here, and air is going to move from high to low pressure, so high pressure inside the lung to the lower pressure outside the lung. Air will move out of the lungs. So if we look at this in a series of steps, the first step, I'm going to put a text box here so we can be sure that we have this in a nice orderly fashion. Step number 1 is that the diaphragm, to get breathing to begin, the diaphragm and external intercostals contract. And when they contract, the volume, the thoracic and lung volume increase. This increasing volume causes the pressure inside the lungs to decrease. As a result, air outside the body is in higher pressure than in the lungs, so air flows into the lungs. So this is the process of inspiration. In order to get air to flow, we have to have a pressure difference, and that pressure difference is caused by increasing thoracic and lung volume. That's the key concept here. That's the first thing that has to happen, is we have to increase that volume. So the question here, in order for air to flow into the lungs, what must happen first? The answer would be increasing lung volume, because that creates a low pressure environment and air naturally flows from high pressure to low pressure. So what we can do is take measurements of individuals' lung capacity, and the way we do that is by having them blow into a hose with that goes into a machine, and it's called a spirometer. And this will tell us the volume of air moving in and out of that patient's lungs. So here we can see the graph rises upward and downward to a difference of 500. So we inhale 500, we exhale 500. We inhale, we exhale. What this large deflection here is called is if we inhale, or if we inhale, exhale, inhale, Once we inhale, we can inhale even deeper if necessary, up to a volume of 3,100 more milliliters of air if necessary. So we have an ability to bring in more air if necessary, but our regular quiet breathing is 500 in, 500 out. Here we can see the same thing, 500 out, but once we're done exhaling, we could exhale more if necessary, another 1,200 milliliters more necessary if we wanted to. But what we find is we can always inhale more than we can exhale. And the reason for that is we wouldn't want to exhale all the air in our lungs because we need some air to keep our alveoli open and for that air to be available for constant gas exchange. So this is what we call residual volume, and that's the air that remains in the lungs that we cannot forcibly exhale. So the reserve volume is what we can forcibly inhale if necessary. The expiratory reserve volume is what we can forcibly exhale. And the residual volume is what's available for gas exchange and keeps the alveoli open. And that is not something that we can control or remove from our bodies. Again, tidal volume is just the amount going in and out with quiet breathing. So what stimulates our breathing? The major controller of breathing comes from action potentials via the medulla oblongata, and the pons also plays a role in regulating the activity of the medulla oblongata, but it's the medulla that has a direct connection to the muscles related to breathing, which would be the diaphragm and the external intercostals. So these send action potentials to contract those muscles and begin the process of inspiration. We also have other factors that can influence our respiratory rate, and that is in the aortic arch. We have oxygen chemoreceptors that will detect oxygen levels, that if those go low, that will stimulate increased breathing. And we also have the brain that will detect carbon dioxide levels and determine if those are increasing, that too will increase the respiratory rate. And it's actually carbon dioxide that is the major regulator of ventilation. That will determine how fast and how deep breathing occurs, because the carbon dioxide is a good indicator of respiratory function, and if we're not blowing off enough carbon dioxide, that can quickly change our pH of our blood, and that would disrupt homeostasis. Our thinking, our emotions can also affect breathing. If someone hears some really good news or really bad news, that can cause them to start to breathe deeply. Some people even hyperventilate when they're so upset with either good or bad news, and those too are other controls of ventilation. And we don't find that oxygen levels really affect the respiratory rate or depth until they get to be about 50% or greater from the normal levels of oxygen dissolved in the plasma. So it's really the carbon dioxide levels in the plasma that determine the respiratory rate and depth. So the effects of some environmental exposures on the lungs, we call a common one is COPD, which stands for chronic obstructive pulmonary disease. And two types of COPD. One is chronic bronchitis, the other one is emphysema. People who are lifelong smokers usually suffer from both of these, and they are the result of irritants from the environment, not always tobacco smoke. It might be air pollution. It might be from working in an environment where there's a lot of particles in the air, and that can do permanent lung damage. So that causes, with emphysema, the alveoli collapse into one another, creating these large air spaces in the lungs, and the lungs are trapped with air that cannot be exhaled normally. Chronic bronchitis causes an inflammation and damage to the bronchioles serving the alveoli, and that really leads to narrowed airways, chronic cough, and excessive mucus production. So we typically have patients that are on inhalers and oxygen when they have advanced COPD. Lung cancer is another problem that is increased by smoking, but not all people who have had or have lung cancer are smokers, but they are the largest percentage of lung cancer patients are smokers. And what happens is the tumors, here we can see a tumor in the lung here, that if it's not caught early enough, which small cell lung cancer is the most serious of the lung cancers, it isn't detected until it's spread to the rest of the body. And what we call lung cancer that has spread, we say that it has metastasized. And common places that lung cancer spreads is to the liver, because we can see it's nearby, and the blood supply is nearby the liver and the lymph node network that can carry cancer, as well as the spine and the brain. Those are common places that lung cancer can spread to, and those are obviously very important tissues and organs necessary for life. So once lung cancer has spread to the rest of the body, it's very difficult to treat, and survival is not very good. So as we age, we find that our vital capacity, which means the total amount of air that moves in and out of the lung, that decreases because the rib cage stiffens, the mucus becomes more sticky and less able to be coughed up. Abdominal muscles are weaker, and patients can't clear their secretions very well. They can't cough up mucus when it collects. So we see just overall dysfunction and declining efficiency of the lungs. The amount of volume and dead space in the lungs increases because of these collapsing alveoli. So the surface area for gas exchange decreases as well. So therefore, elderly people have a hard time getting good oxygen and carbon dioxide exchange, and as a result they tire more easily, they get short of breath more easily, and they need more assistance with doing daily activities. So of course the best thing we can do to preserve our lung function is to exercise, because when we challenge our lungs with deep breathing, that stimulates surfactant production, that stimulates the muscles involved with taking deep breaths, and that keeps our airways clear as well, and less people who exercise are less prone to infection, and as a result live longer, healthier lives.